got a gas right now that she sent me.
Call anesthesia.
One set. Yeah.
Serious vital signs. Is anesthesia
Mr.
been called?
Sperliza, there's just blood pressure.
Has anesthesia been called?
Does anybody have a
Come on.
tourniquet on them?
Is it the other way around?
I just sent a gas.
Do you have a tourniquet?
Check the second floor.
Then try and get a line in.
Do you need any drugs, Suzanne?
Yeah, can you get me the intubation? Get me all the drugs from the kit. I don't have anything in here. Oh, he's on the wrong. Yeah.
He's just not breathing.
He just suddenly stopped breathing and I was getting an EKG. Yeah, he went into a weird rhythm, so I had to get an EKG and just started dropping his pressure and turning blue. I just sent it, yes. Neo single strength too.
Do you have a section?
Right here.
What is it? G2, the section, please.
So on that side, you want to just...
Can somebody turn on the NG2? Have the suction over there.
Okay, I'll get over this.
There's a strap on the back.
There's a strap.
You might have to figure out.
Yeah, it's a little.
Is that even needle for this? Yeah, that's all we use. Okay. Saline's going in. Gloves, okay, gloves, big and small. Get it?
Are you?
No. His blood pressure's obliterate 70. Okay.
Can we put him in Gallenberg?
Yeah. You know what? Come on, I'll wash them off.
Can you mix up some dopamine, please? Yeah, just to...
Dopamine?
I'm just going to try this one.
Alcohol?
Yeah, we'll go down. I'm moving the head down, okay? There.
Just trying to put it around.
Okay.
No, just wait a minute. It's like a
Yeah,
rock,
it's an
but-
anti-cube right here. Can you just unplug that amino, just pop it out?
Josh Riley, think about 7-ish.
Take care of him and then go finish round.
Whole bed's gonna look good in about 5 minutes.
Do we have a triple Bowman thing?
Yeah, right there.
Can you just open it, stick it on there? Looks good.
Yes.
Do you want a quartus,
Do we still want this fluid running wide open? It's the gas. Turn that down and just use that.
What, Karen?
Neo? Okay, did we get any gas back there? Nothing. That sucks drawn up. It was too fast. Push through here.
Where was the dopamine?
The central line.
Dopamine is going from second one wide
Yep, wide open. 500 an hour. Saline is wide open. Can we have some more saline? Blood pressure 60. Do we have any atropine ready? Atropine? Yeah, coming.
Is that on wide open Neo?
Wide open Neo,
Wide open Neo, wide open Dopa, wide open fluid. Is that correct?
That's correct. Obliterate 50.
Pulse is definitely.
Dopamine. No. Newport is saline.
All right, good. We need a saline spot. We can do it. We can do it.
I'm
They want it.
Okay, doctor. Go to it.
100% bags, 302, 100 milligrams of Lido. Okay. Okay, 100 of Lido going in. Okay.
I got it.
So you want to put him in sync mode at 50?
You want to zap them out of this? All right, here we go.
Charge it all.
You can charge there.
Persistent blood pressure.
Clear.
Clear. Yes, you're still touching the metal bed. Yeah, Jeff.
Yeah.
Paul,
Charge.
Okay, go ahead.
right leg back.
Clear.
You got to hold it because it's sinking his own. So
Okay.
it won't go right away. Woo.
Well, now you've got.
Some,
Oh, now we've got
we got V
kind of ventricular.
ventricular.
Attack.
No, it's awful
No.
slow.
I know.
if he's got
Hey, we have a good blood pressure here, just a second. He's got a better blood pressure with it. And when he ends, he has 70. Wait, hold on.
Don't shock. Looks like a flutter almost up here.
Blood
There you
pressure,
go, that's
she's got a
better.
blood rate. She's got a blood pressure 80 by
80.
A-line.
it's a narrow complex now.
Yeah, it's a long here.
Narrow complex with inverted teeth.
He's switching, it looks like he's switching bundles or something. Can you tell up there?
Some bundle and a low pacer.
The P waves aren't much.
Blood pressure's better.
That looks like P waves with a bundle.
I just turn the amplitude up a little bit, Sue. Yeah. So that picks up the heart rate. Thanks. Is it flutter?
I think it might be sinus.
See those spikes you see? That's
62. So is this chest all good? That's fine. Yeah, give me that Neo and dopamine still wide open. Yeah, whatever.
Why don't you start
So
that
he's actually 70 systolic right now?
Listen, you know why he's probably hypotensive now? Or one of the reasons he may be no. I think that one of the major reasons is that we may have blown off his CO2 too much, and I think it would be a good idea before we start pouring a lot of drugs into the guy to get another gas and see where you are, because he's alkalotic. You know, his baseline PCO2 is like 60, 70, and I'd slow down actually a little bit, Frank. And I mean, because oxygenation was in the, and I think that his pH could be 7.55, 7.6, and that could be all that's going on here. So I could take responsibility for this one, guys. When I saw him this morning, I should have told you to go ahead and intubate him right then. No, he was not breathing this morning very well.
He was moving a lot of air.
You know, I think the problem is that he was so down mentally because he's been that way. You know, so that. But I think that's.
But I mean, something happened,
I mean, I would not make a big
ventilating
thing
and then
about not putting a central line in him last night. I mean, the central line is not the answer to the guy's problems. But if anybody made a mistake, I made the mistake this morning in not suggesting that we go ahead and intubate him electively. So I think that's where the.
Well, but I think
was.
something happened. I mean, between the time we.
I don't know. I don't think. I'm not sure. I'm not sure.
He was breathing.
He just pooped out.
I think he just pooped out. I think he just pooped out. I mean, he was pooping.
We gave him
He was
chest
pooping
BT
over
suction
24 hours.
Within 15 minutes.
He was pooping out over 24 hours. You know, I mean, he didn't look good yesterday in the evening, and he sort of gradually didn't look good. Okay. You know, all night. So I think that's basically what happened, and I think it's just a question of a guy being dry, infected, and not waking up from the Ativan and not having a great respiratory drive.
Charlie, can you hear me? Charlie? I'm not very responsive. Thank you, you guys. Thanks, everyone.
You want
You want to keep this on?
I think that now, I think that pretty clearly he's going to go down to valvuloplasty on a ventilator, and maybe it'll make him better, and maybe it won't. But we don't even know, after all is said and done, what sort of a brain we've got here after all of this stuff. So, we're going to have to reevaluate the whole situation after we sort of get him stabilized. The thing that's tough is that you get a case like that, and you got a 1 in 100 chance of pulling the guy through, and you work like hell, and you stay up all night, and you're almost there, and you think like he's going to make it, and then he goes down the tubes again. But like I say, you do your best, and that's all you can do. And I think that aside from, everything would have been fine if Scott Weiss had said, look, we got to call anesthesia and get them over here and intubate him electively. I think that was a mistake on my part. I don't think that anything that you guys did last night did or didn't matter. If you look at the course of events, he was sort of dribbling a little bit as we went on. Let's finish up and see the rest of these people real quick, because there's enough stuff to do here to keep everybody going for a while.
Yeah, she still is. Okay. Rapid.
The tendency here is, for all of us, certainly for Woody and for me, the tendency is in general to say, stop.
We have a warped sense of looking at things.
That's right.
Cancer?
That's
he doesn't have a chance.
right. That's
These people
exactly.
that get better.
That's right, and that's why I think that because that's the tendency. It's it's very important to, give him the benefit of the doubt. I mean, look, so Mr. Cabra got an extra 10 days on the ventilator before.
I agree with you. I am a big believer that everybody deserves a chance. I don't care what you have, go great guns. But then when you're working on the month, the 2 month, the 3 month,
right.
There comes a time when you got to realize we've offered everything we can.
All right.
We've
I think the other thing, though, is that I've never had a problem ever in dealing with a family about any of this stuff. No. I'm not plenty of problems with things. As long as I was the first, as long as I was able to establish a relationship with them and get there. I mean, the problem is that you get into the situation where
You guys switch around.
certain, stuff has been done before they come here.
They come with a lot of baggage already.
Yeah.
I know what you're saying.
Well, that's why I was. When
I mean, there have been a few situations, really crazy families where, no matter what you did, you could never.
Yeah, the gypsies and stuff like that.
No,
I'll never forget
gypsies,
that family.
but I think in general, if you have a good relationship with them and you sort of are honest with them about what's going on, say, look, your father, whatever, is
But that's why I
dying.
think we have more problems with asking people here. It's house staff, it's a changing, and we want to keep getting to know the family. How do you feel? What do you think? Have you ever talked about this? Where on community hospitals, other hospitals, there's an attending and there's a family. He's probably taken care of them for years.
Yeah, I mean,
or knows the situation.
Where my sister practices, in Caribou, Maine. I mean, she's taking care of these people. And she doesn't, she doesn't. I mean, I can tell you, I'm sure, somebody comes into
I know
a
your sister. I can see her
hospital there.
working at
She doesn't say, what do you think? I mean, she says,
This is it. And this is
your
why
father's dying.
Right.
But if you don't know somebody, you've never seen him before, it's very cavalier to say,
well, I know more than you
I'm Joe
do.
Schmo.
check out, I'm sorry, but, you...
It's all over.
So you end up... and clearly, clearly the house staff's sense of... if you haven't seen 10,000 patients, even if you have seen 10,000 patients, I'm not ever sure. I'll tell you,
100%.
Mrs. Perglin, there is a good example. I'd never seen that lady before. She shows up here, all the stuff that went through my mind was, has she, have they really established the diagnosis? What else could she possibly have? And I started asking myself all of these questions. I mean, you still get uncomfortable about...
It's a big...
I'd never seen her before. And yes, they say she refused chemotherapy in New York, but did she really? And what were the circumstances? And what was she told? And so it's if you're cavalier about somebody like that, then you want to get out of the business. I mean,
No, our best friend get diagnosed with similar
But I
things
think-
and die 2 weeks
I
after
think
chemo.
too, though, part of the job is, unfortunately, is like you said, to take responsibility for it. To also ignore that. I think a lot of people, because they have difficulty with it, almost like, especially certain, like an attending physician, almost puts it on to, say, the attending of the unit, or they have the relationship with the patient, but because they have
well, in
a
her
hard
case,
time.
that wasn't true. I think you're right. Is what you're saying is that in a
Because it's a
situation
hard
like
thing to deal
in a
with.
situation like her, they would take all of those uncertainties and they would make them very nervous, and then they would just advocate and say, and you got to make a decision. But I think you got to be very, very sure. There are few situations, though, in life where the critical meaning of what you say and how you say it has as much ramifications as it does around this issue.
How you doing? Oh, more bad news.
What?
I say there's more bad news, one thing after another with what's been going on. Right now, there's no change since I spoke with you, but this latest set of episodes is
Something different.
not from when we spoke on the telephone, but he hasn't shown any recovery from that. They're giving him some other medication now to try to help his heart pump a little more effectively, and to see if that could be helpful. It's been a whole series of one problem after another.
Why? He's been coming in so long. He never had these problems. What happened?
Well, I'm not sure we have the complete answer to that, but in the attempt to see how he's doing, getting him off the breathing machine, it looked like things were getting better and better. He was remaining stable, but he was in such a precarious situation that after we've seen some of the things that can happen from that. I don't have an answer for you as to why it was that it happened now. It's possible that there may have been some additional injury that happened either to his heart or elsewhere that we haven't detected yet, and that may be the thing that caused all this.
Is he holding his own now?
Well, I guess it's fair to say barely. I think in the last hour or two, his blood pressure has been a little better, and his heart rhythm has gotten a little bit stronger. His heart rhythm had been irregular, and it's now more stable. But I think the big picture still looks very grave. Excuse me.
Are you telling me that he doesn't have too much hope?
Well, I think there's always hope. We don't know for sure how to predict the future, but I think these things all make us concerned about, make us wonder. We don't know. But each one of these things that happens is more bad news and more for him to contend with if he's going to have any sort of meaningful recovery.
Didn't he respond at all?
No, but we don't know if that's because there's an underlying problem that's causing him not to respond, or whether it's still a lingering effect from the sedatives. Even off of it for a couple of days, his kidneys have been not doing well, and his liver has been not doing well, and those are the things which get rid of the sedative from his body, so that it's possible that some of the effect of him not waking up was from the medication. But I think we also have to consider the possibility that even once the medication's gone, that we may find an underlying problem that's responsible for him not waking up.
He was always complaining about his kidneys. I just feel so terrible. He was so unhappy to come in here. He was so sure he was going to die. And I think that that's uppermost in his mind.
That he was sure he was going to die.
Yes, that's all he said. And of course, I said, gee, Charlie, you've been doing pretty good. You know, he managed around the house, but at the last week before we came in here, he couldn't even go from the bedroom to the bathroom. Well, I'll put it in the hands of God. There's nothing I can say or do except pray. Can we go in the room?
Let me check with the doctor, make sure that it's okay now. I'll be right back.
The technique is poor. But for now.
You're really feeling it?
Yeah, she is. Yeah, Phil.
Probably the smart thing to do. A little bit, not much, but I had to give him some medicine to put him to sleep again to keep him comfortable.
Can we sit here quietly? Okay.
Cheers. We'll talk to him if you want. I hear you. You can hold his hand if you want. It's way down here.
Charlie. Why have you got the tape on his eyes?
Because his eyes were wide open. wasn't keeping him closed by himself.
Oh.
So I didn't want him to get dried out. It's more comfortable that way.
Patrick's girl. Hi, Charlie. Charlie. Do you hear me, honey? Do you hear me?
You understand what happened today?
No.
Well, he was doing about the same as usual.
Yeah.
And then he just got pooped out from breathing. He just suddenly tired out completely and stopped breathing. And
Stop breathing?
He stopped breathing completely. So we had to put him back on the ventilator. But his heart, at the same time, had started to go into a funny rhythm. And he dropped his blood pressure, too. He's on a lot of medications for his blood pressure right now.
I don't understand. He wasn't this sick at all. He supposed it was coming on?
It was coming on. Might just be this time. You know? He has a sick heart. He has a pretty sick heart.
Yeah.
Yeah.
He never get treated for that. Had any problem for it?
No, he was on Captopro. That was for his heart.
Oh, was it?
Yeah, he was on a couple heart medications at home. And that's why his lungs kept getting bad this year.
Yeah.
It's because his heart wasn't pumping right, so the fluid was backing up into his lungs.
Oh.
Yeah.
Can you tell if he's doing better or not?
You watch his blood pressure and his heart rate.
Oh, that wouldn't do me much good.
Just his numbers. That's all
Yeah.
we can go by right now. He has gotten better over the last hour.
Really?
He's gotten a little bit better. His blood pressure's gotten better. His heart rate's come down. We've taken him off some of the medications, so he's getting better. But he had a pretty touch and go morning.
And I called last night about 8:30, and Allison said to me, he's having a little trouble breathing. So he must have started getting bad last night.
He started getting bad last night. His breathing was okay, but his heart went into a real fast rhythm.
Oh,
And they had to zap him, cardiovert him around 5 in the morning to get him out of the rhythm.
oh,
Yeah, and he was stable for about 4 hours. And then his heart just kind of slowed down and he stopped breathing. So we had to put him back on the machine and we had to zap him again.
I don't believe it. He was a tiger. If you knew how I used to beg him about those cigarettes. Can't blame it on any one thing. We're gonna stay around if you don't mind. We won't,
You're coming over here to sit down. Dr. Taylor talked to you. Well, at this point, if his heart were to go into a bad rhythm or if it was to stop again, we can give him drugs and we can shock him and we can try to save him. Or if you think that he's gone through enough, you can decide for us to not do that, to just keep everything we're doing right now but not start anything else. If you think you've been through enough with him.
Oh no, I'd want him to have every chance
You want
there
him
was.
to have every chance. Okay, we have to ask you that, and that's
Yeah.
very reasonable for you. So we can pass that along. I'll tell Dr. Taylor that, or if he doesn't ask you, I'll pass that along.
Okay,
That
thank
we'll
you.
do everything for him, okay?
Every conceivable
Everything we
thing.
can do. Okay.
You've been so good, Suzanne.
I know this is difficult for you.
No, I don't think you do.
Yeah, I do. I
He's
see
my
this every
life.
day.
He's my life. I'm so afraid I'd go and leave him alone.
Really?
I didn't even drive in today because I was afraid. We had to wait 3/4 of an hour for a cab. I don't think I should be driving when I feel like this.
Yeah, I think it's smart. When's your next appointment to come in and see me?
23rd. Charlie had an appointment with me too.
Yeah, I remember we set that up.
Yeah.
I'll see you sooner if you think that would be useful.
While Charlie's still here, I'm not thinking of anything.
What's your sense of what's going on with him now, Mrs. Brown?
My son,
What's your sense of what's going on with him now?
I think he's in bad condition.
You feel like you have an understanding of what's happening to him as much as you want to have?
Not really. I can't understand why he's so sick. I mean, you're mentioning liver and kidneys. And how did they all enter the picture?
Well, what happens from whatever the original cause is, when the heart is not pumping efficiently and the blood pressure goes down, the circulation to every organ is affected. And, you know, part of what the heart does is supply every organ with oxygen. When the lungs aren't working well, not as much oxygen gets in. And then when the heart is not pumping well, every organ can be affected by the poor circulation. And I'm afraid that's what he's been through, is that the heart problems and the lung problems have probably set everything else off. His kidneys are not working well at all. His liver is not working well. His blood sugar is out of control. As we discussed on the phone, we have questions about whether he might have had any brain damage from what had gone on in the few days before. And we were hoping that once we could stop the sedatives when he was off the machine, that we could see if he would wake up at all as a sign that his brain was doing okay. So we have, everywhere we turn,
There's
the
an
multiple...
obstacle. You know, he said all week before I come in, he screamed. He said, I'm going crazy. You know, I'm going crazy. He said, it's just like, you know, the girl that used to take care of him that went to California. He said, I feel worse than when she was here.
When Dr. Gartrell left.
Yeah.
Yeah, that was a big loss for him.
It was a big loss for him. He didn't particularly take to the doctor that took her place.
Yeah. Well, I think any time there's a close relationship, as he had with that psychiatrist, finding a replacement is very difficult.
I know. What can I do, Dr. Taylor?
Well, I think to be there the way you are is probably the most important thing. You know, we don't think that he's able to sense much in terms of what's going on around him, but we never know. And I think, you know, your presence, your visits are probably the most important thing.
My son came in last night, much against his will. He just can't bear. And he's He's so good. But sickness just does up to him. I to see somebody in under these conditions.
Yeah. Would it be useful for him to talk with me?
I don't think so. Because I'd say almost he was a Christian Scientist if I didn't know better. He won't go to a doctor himself. He has a Harvard plan. If he hurts himself some way, he'll go to a doctor. Other than that, he heals himself.
You might mention to him, if you would, that I'm available if he thinks it might be useful for us to talk. Even if it doesn't mean coming in, we can even speak on the phone. You know,
I will if you don't mind, because I can't talk to him without breaking down, and then he gets upset when I break down, and I don't want to do it. I don't do it intentionally.
Well, it's not necessarily a bad thing for him to know how you're feeling. You know, one of the big questions from a medical point of view is whether we should go ahead with this procedure that we've talked about doing, where they put the balloon in and try to open up the blockage in the heart valve. And it's a very, very difficult issue because, on the one hand, with all the difficulty that he's having, we don't want to subject him to the further difficulty that could come if there were a complication from the procedure. Because on the one hand, if it would offer him something and a chance of a more meaningful opportunity to recover, we certainly don't want to withhold that from him.
No.
On the other hand, if it means putting him through one more procedure for no purpose, if it's not going to help him have a more meaningful chance of recovery, we'd hate to subject him to it. Not only for what the procedure does, but in case there could be any complications from it or any problems, because although it's a relatively safe procedure, there are complications from it occasionally.
I know he explained it to me.
And in his condition, the possibility of complications always goes up. You know, when there are so many things that
So what does that leave you with? Nothing?
Well, I don't know. I think it leaves watching, trying to do the best we can to stabilize him, and then to keep making this judgment as best we can with the best input we can get. You know, Dr. Morgan has known him for a while.
Oh, yes.
He's very thoughtful and careful about giving advice about these things, and I think his opinion is going to be a real important one in terms of whether he thinks this might be helpful. Because, you know, back when he was evaluated, when Charlie was evaluated in July, it didn't look like the heart valve was causing the primary problem.
I know. That's why I don't understand this.
Well, one of the things that says to me is that we have to be careful. We don't want to rush ahead and subject him to something unless we're pretty sure that he's likely to stand to gain from it. In the meantime, every additional problem that develops is another strike against him in terms of what we're all hoping for, this possibility of some meaningful recovery from this.
Is it possible that medication will help him?
Well, he's on medication.
Yes,
I
know.
We're trying different ones to see if we can find the best combination for him. So we're doing what can be done with that, and not giving up in terms of trying to be helpful. But I think to try to be realistic at the same time, the more this goes on and the more complications that develop, in spite of doing everything that's being done, the worse it looks.
He's not suffering, is he?
No, to the best of our knowledge, he's not. When he's been resisting the tube or looking like he's at all uncomfortable, he has gotten the sedative medication to try to take the edge off of that and to try to make sure. I believe, since this tube has had to go back in, that he hasn't required much in the way of the sedative, either because there's still some in his bloodstream or because he's so sick that he's not able to fight it or to experience it.
So what do you think? Wait and see?
I think that's all we can do. And I think in the meantime, we have to keep assessing what's our goal for all this. I mean, clearly,
yeah, that's what I want to know.
If there is some hope for some meaningful recovery, we want to do everything to help him to achieve that. If it reaches the point where that isn't really possible, then we're going to have to reassess and say, is it the right thing to do to subject him to all this, to the tubes and the machines and the medications and everything that goes on here in intensive care, if it's not going to be for some purpose in terms of him being able to recover from this? And at this point, I think we don't know. We never know for sure. But the longer it goes with more and more complications, the less he responds to all the different things that are being done.
Well, couldn't it be just the opposite, that he won't start responding?
That's the hope.
Oh, Dr. Tim. Well, I'm going to go along with the hope. That something will be resolved.
Let's stay in close touch. You know how to reach me anytime.
Oh, yeah. I called you yesterday, and Paige had you on the line so long, and then I just hung up, and I tried Dr. Morgan, and I got him.
Good. You know, sometimes when they page me, the beeper doesn't go off. So what you can do is call and page again when that happens.
Oh.
Okay?
I thought maybe you weren't on Page, you know.
No, they'll know that. And if they tell you that I'm not on Page, ask them for a number where you can leave a message for me, and then I can call you back. Now, there's always, if I can't be Page, there's always a place where you can leave a message.
Oh, I didn't know that. Thank you.
Yeah. Tomorrow I'll be here all day and on Page all day. So you can speak to me later today through the Page operator, or tomorrow I'll be here.
Oh, Dr. Morgan was very nice. He spoke to me. Oh, I don't know what that doctor's name was. He told the most horrifying things that can happen with that procedure.
Yeah, well, it's a terrible
But of
list.
course, I imagine that they have to do that, you know.
That they have to do which?
Tell you all the bad things that can happen.
Yeah, I'm afraid they do. Because the last thing that you'd want to have happen is to have them go through it and have something happen that you never even realized could occur. So they want you to sort of have your eyes
They've
open.
only done 140 of these.
It's a brand new procedure. Most hospitals, my understanding is most hospitals don't have it available. We're fortunate to have people here who are skilled in it, but it's brand new. So doing it has its hazards, even though they appear to be small. And we also don't really know about the long-term effect.
That's what he said. And you also don't know if that's what he really needs.
That's the key. That's what we're trying to sort out. My own view is that we need to hold off on that right now and see if he can start to show some signs of turning the corner, being stabilized, looking like there's some chance of meaningful recovery. Because I would hate to subject him to it and have it be for no purpose, or even worse, to have it be something that causes him additional problems. So if it looks like he's able to hold his own, he is able to start to show some signs of recovery, I think we'd have to assess whether it might be worth doing. And as I say, I'll depend very heavily on Dr. Morgan and the rest of the cardiologists about whether
Will Dr. McKay be in on this?
Yeah, well, Dr. McKay is the one with Dr. Safian who are the experts on doing it. So
I see.
Dr. Morgan's consulting with him all the time about whether it's something that would be useful for him, or whether it should be done soon, or we should hold off, or just what would be the best sort of plan.
I don't know what I'd do without her. I mean, she walks my dog in the morning. Poor dog doesn't know where Charlie is. He keeps going and look at the bed, and he's so sad. He leaves a hole everywhere. You know Charlie from here. But Charlie is one of the, greatest. That's all I can say. The kids adore him when they see him coming down the street. If your Daniel saw me fly in his arms, that's the way he is.
Yeah, I know that about him.
Yeah, he loves children. And the kids have all asked me, yesterday they gave me drawings to put in this room. They were horrible. I didn't dare tell the little girl what I thought it was. I thought it was a candle. She said it was a Christmas tree.
She's working on it.
She's working on it, yeah.
maybe the spirit of what's behind that isn't
That's
lost on
right.
them. All righty. Well, I'll be around later today, as I say, and
Yeah.
tomorrow as well. So
Yeah.
let's stay in close touch.
Oh, yes. I may go home for a little while, straighten the dog out, lock up the house.
Uh-huh.
But I'll be back. I'll get a ride back. I won't drive.
Good. Well, that's the right thing to do.
Right. Thank
Okay.
you so much for your
All right.
time and your kindness.
Good to see you.
Thank you, Dr. Taylor.
So I just, tried to explain to the wife in pretty simple terms the scenario, things she's aware that he is doing very, very poorly. But she still very strongly feels that she wants everything done for him.
Did someone bring it up and she definitely said she wants
I said to her, if his heart stops, and or if he goes into a bad rhythm, I said, we can shock him, we can give him drugs, this is what you want. And she said, oh God, yes, I want everything done.
Okay.
But the sister, I think, has a little bit more realistic view of the situation, and she's not as emotionally involved.
She might just need time to accept
I think she,
this and then,
yeah.
and then it'll come around.
And that's what the sister said, and I said to her, I said I would not be surprised if something sudden happened, and I said I really don't want to mention this to her. I said, but just don't leave her alone at home. I said, just be prepared that something could happen, and that he's doing very poorly. And and she seems a lot more reasonable.
I assume nobody has gotten a bed.
That's what I figured. The wife, she's really heartbroken. I mean, she really loves Charlie. She doesn't know what she's going to do without him. She knows now he's going to die.
Oh, she's very sick since he's been sick. She comes in here and she's been dizzy. And
Has she really?
Yeah.
I didn't know.
Yeah.
Wonderful.
Mr. S is... Mr. S...
Thanks for getting me lunch, Ken. I haven't eaten yet either, God.
You can leave the
going
cup
home.
if you want.
You're going home now.
Absolutely.
I'm going home now
I'm
too.
going to the bar
You are
now.
not.
And that's all. And who's it? Taylor has spent time.
He's very good. He's very good. He's very realistic. He sees them every day.
I think
He was saying they wouldn't give a valvuloplasty if this man mentally is not with it. Like if he's had a stroke or whatever that we haven't discovered yet.
Well, he was on the list for valvoplasty tomorrow, and they canceled him, and they're possibly going to do it on Monday.
Yeah.
We know they're not going to take him.
And
There's no way he's stable enough to go down for that. So,
you just have to wait and see. You'll know by
So what do I need to do? Finish 40%?
I need that blue book big time. We can go in and see him first. I'm going to go down and get something to eat.
you goes either one way or the other way.
All right, thanks.
Yeah, just be home at 7 when it's next.
Okay.
Ooh, he must be upset. His blood pressure's 153.
That's good though. Mr. might confuse his kidneys a little better.
DC. The DC.
Again, I think the real problem is we need to get together with Jim again and sort of think about whether there's anything that... I don't really know why he crumped. This history of it is much more consistent with a respiratory thing, that he was... from his heart, he was as maximal as we could make him. I think he was well diuresed and he looked pretty good. And I think that he had a high white count, and it may be that just, the combination of the sedation and whatever infection he had, he just gradually went downhill over a 36-hour period. So it was more respiratory decompensation. But what bothers me is that his lungs are so bad, and his heart is so bad. We got his heart to the best we could get it, and we still couldn't keep him off the ventilator.
Yeah.
And that doesn't bode very well for a valvuloplasty.
That's
What
right.
that says is that even with a valvuloplasty, I can't get him on the ventilator. So I think we just need to sort of sit tight for a day and sort of see what happens, because he's got some ATN. It's non-oliguric probably, and it looks like he's starting to pee now that we got everything metabolically under control. The guy's being ruled out, there's a whole bunch of other things. But then I think we have to sort of sit down with Jim, and I'd be very pessimistic that valvuloplasty would do anything. But I also don't think I'm going to get him off the ventilator. So, it might be
But
helpful.
to do a valvuloplasty that's not going to help is not a reason.
That's what I think at this point. And so...
Well, Jim knows him well, so...
Yeah, I think just we need to sort of touch base with him about that and sort of say, okay, look, is there any, what is, because my feeling would be, forget it at this point. But then I think that, we'll both have to talk to his wife and sort of explain to her what the situation is. I think we may get him to the point again, when we can try to extubate him. But if we do that, I'd be in favor of not putting him back on if he didn't fly, probably.
Yeah, I think the question is all for what?
Yeah. Well, I think then it would be hopeless. I don't think we would really. There wouldn't be any chance except sort of prolonging his death.
All right, I'll talk to Chris some more today, and we'll catch up with Jim.
Yeah, we talk to Jim, and then we'll see. I don't think we have to make any sudden moves over the next the weekend.
Good.
See what happens.
Thanks, Scott. The question is going to come up if we are able to take out the tube and see how he does. What happens if he does not do well? Certainly if we take it out, it'll be our hope, and we'll do everything we possibly can to see that he does well without it. But if his breathing becomes a problem off the tube, again, we're going to have to face the issue of whether to put the tube back in or not. Excuse me? Well, that's the question. I think, it can only be used essentially for the kind of support that he's getting now. We would hope that in the long run that he'd be able to manage without it. If we have to put it back in again, the question is for what? In other words, what sort of a recovery might he have if he's unable to breathe except to have the machine breathe for him? Are you going to be in today? Uh-huh. Yeah. Uh-huh. Yeah. Well, would you rather talk about this sort of stuff in person? Yeah. Alrighty. Well, when you come in, why don't you ask the unit coordinator up here in the intensive care unit to page me, and I'll come in and we'll speak then. Okay, because I think the issue that we started to talk about is one that it'll be important for us to talk about some more. Well, we'll talk about it together. I think you have to understand as best you can the medical situation. It's my job to try to tell you as best I can about that. And then together we'll try to figure out what's the best plan and what to do. Okay, I'll speak to you later. Take care.
I think if we're going to play around with valvular placement, we got to do it while he's intubated. I don't think we have to try to extubate him. At the moment, it's not clear at all to me that he could come off the ventilator.
Yeah, it's also not clear to me that he stands to benefit a whit from a valvuloplasty.
Right, but those are the questions we had. I guess the other question to put to Jim is, what he thinks about cardioversion, since we've got his rate controlled, but he may not be able to hold the cardioversion, and obviously
He's been repeatedly in sinus rhythm, right?
No, he's in AF.
he's in AF now.
It hasn't been in and out of AF. It's been a period.
Pretty much been in the last couple of days, but he does go in and out.
He's digitalized now, so his rate is control. Anyway, I'm not big on either one of those, but
Yeah, we can do more and more technologically, but the question is for what?
yeah, well, so
I
I'm
think
not,
if he can't be maintained off the respirator, the big for what becomes, sort of written in large letters.
if we take him off and he doesn't fly, I'm loath to put him back on.
Yeah, I agree with that. Well, she's coming in around 3, and I asked her to give me a call, so
Good.
maybe we'll keep the plan as it is right now, speak to Jim, and then
Right.
see if we can evolve something toward that.
Good, okay.
I'll speak to you
Okay.
later. Thanks.
So, can you close her door?
What did you say about that?
He says he doesn't think it.
He doesn't.
This is more technology for unclear benefit.
Okay.
What do you think?
Well, I think that if that tube could come out, it would be a big step forward. There's still all the other problems that haven't gone away, since we spoke last time. but they've been relatively stable, and that gives us reason to be hopeful, I think. It's still an incredibly grave and difficult situation, but I think if he could come off of that tube, it would be a big step forward. And clearly, if he's going to be alert at all, it's going to be hard for him with that tube in place. He has to get sedated in order to have it be tolerable for him. So that's a difficult situation for him, either to be a little bit more alert but have the discomfort of it, or to be sedated and not really be able to
Well, I wouldn't want to see
participate.
him go back into the sedation part.
No, I wouldn't either.
I really wouldn't, because he's not there at all.
Right. And yet with the tube in place, without the sedation, he appears to be quite uncomfortable. So I think if it can happen safely, what we want to have happen is what we're making progress toward again, which is to try to get that tube removed and to get him off of the breathing machine. If that goes well, we'll have a lot to be thankful for. We have to also plan, if it does happen, what if he has another breathing problem again? Are we going to subject him to the tube and the machine for a third time? And we have to ask ourselves, what would the purpose of that be? Hopefully this isn't anything we're going to face. I mean, hopefully he'll come off that tube and we'll see some improvement. But the fact that he's had so much difficulty, that there's been so much trouble with so many different things, as we've talked about, makes us have to have our eyes open, even at the same time that we're hopeful to the possibility that things aren't going to go well. And I think we have to plan for that at the same time that we're trying to do everything to help him move in the right direction. My own view would be, and hearing from you people about this is going to be crucial, but my own view would be that if we're able to get him off the tube successfully, that gives him the maximum chance of seeing whether there's any possibility for meaningful recovery. That we do everything we possibly can to get him off the tube. We do everything once he's off the tube to try to keep him off of it. But that we make a decision not to put the tube back in again, if that's something that you people are comfortable with. And the reason for that would be the notion that putting the tube back in would be for no purpose, in the sense that if he deteriorates to the point where he needs it again, that the likelihood for any meaningful kind of recovery would be so remote that we'd say, why are we putting him through all of this? I don't know that's a lot to hear and to think about. I don't know if that makes sense to you or if you have questions about it, but I think that's the sense that I have. I've spoken to Dr. Sands, the intern, and I've spoken to Dr. Weiss, the attending in the medical intensive care unit, and I've spoken to the nursing staff and to Dr. Morgan, the cardiologist. This morning I've spoken to all of those people, and they all believe that this would be a reasonable way to try to maximize the chance for a meaningful recovery, and yet, if things don't go well, to minimize the chance that we're going to be doing needless things to him that are going to be difficult for him, really, for no purpose. We're on the edges of
Did you ever have a case where this was reversed?
I've been involved in cases where people have looked desperately sick and where they fooled us and recovered. But I have to tell you that is extremely rare, and I don't think that I've ever been involved with someone as sick with as many strikes against him as Mr. Speraza has, where I've seen a meaningful recovery. But that doesn't mean it doesn't happen. It's just extremely rare. We have hope. We are doing what we can to try to see if that's possible, but I think it's at the level where if he were to recover from this, it would be close to a miracle.
Really?
Yeah.
What is the extent of damage right now?
Well, some of that's hard to assess. The most crucial thing, of course, is his brain and how much he's able to recover in terms of his mental functioning. And with the medical complications that he's had, plus with the sedatives that he's had to receive, we can't tell for sure.
So you don't know?
We don't know.
What about the other vital organs?
Well, I could give you a list of the things that are in trouble. I mean, the main things where the difficulty's been have been his lungs with respiratory failure, which has required the machine, and his heart with congestive heart failure that's complicated the situation. He's had irregular heart beating, which has made the heart pump less effectively, and he's got this problem with a blocked heart valve, which we've been going round and round on whether that may be contributing to this. The best assessment we have currently is, well, that's not good, that that's probably not making a major contribution to how poorly he's doing. The other big organ system difficulty is his kidneys. His kidneys have been producing very little urine over the last few days, and added to the list of questionable failure related to his brain, respiratory failure, heart failure. I think we have to add kidney failure to the list, so that in that setting, the notion of some sort of meaningful recovery is extremely remote. But we don't know for sure, and that's the reason to continue to try to support him.
So if you remove the tube, that will allow you to do this surgical procedure?
Well, that's looking off to the future. I think the first step is to see if he can manage without the tube.
Removal of the tube. Yeah. Okay, so you're not taking it any further than that?
No. We were wondering whether that, what you call the surgical procedure, where they'd use the balloon to open up that heart valve, whether that might help him to improve his heart function, because everything's so related to everything else that if we can intervene in one place and make him a little better, sometimes that can have implications. But the current thinking is that that's probably not a major contributor to how poorly he's doing.
So the real question is, all you want to do, you want to see what removal of the tube will do, and the secondary question is, if he can't survive without that tube, should you reinsert the tube? And that's a decision for the family to make, is that right?
Well, it's a decision that we all have to participate in together.
Okay.
In a sense, you could say, well, it's a medical decision. If there's no medical hope, or the hope is so remote that it really is just ridiculously unlikely, can we medically subject him to that? On the other hand, you could say it's a decision for the family, because it's really making a decision to terminate life support, because that's what that tube involves. It's a gray area here where both of those things come into play. And I think if medically we come to a decision that, from the point of view of your role in the family, looking out for his best interest, you're comfortable with too, then I think we don't have to sort out what's on which side of it. But if we don't see it exactly the same way, then we can't really move forward with a plan. We want a plan that everybody feels is medically best for him, but also looking at the big picture of what he would want and what you want for him that's consistent with your views.
Would want to live, but I wouldn't want to see him suffer. He was a chance.
When would you need that decision?
It's possible that he may be moving today or tomorrow toward a point where we may be able to remove the tube. I would ideally like to have, by the time that tube can come out, it would be nice if we were all at a place where we were comfortable with a plan of what to do from there. We wouldn't have to
take out the tube,
yeah,
and you see he can make it, Every day is a good day that you live.
Yep. Then there's no question. Then I think we don't face this difficult
That's
one.
right. I'll always go by your decision of what's good for Charlie.
He's asking you for it.
I know. I say medically. He wouldn't want Charlie to suffer.
No, I know that.
It's so hard.
It is hard.
It really is hard. Don't you think that we could make more of a commitment once you take the tube out?
I'm not sure I understand.
Well, what if you take the tube out, you find that he more or less rallies around? Anything I say doesn't mean she's given me permission to say that's it, but, you're going to do the best for him, and I know that. And if there isn't any hope, if he's going to medically, I would never want him to suffer, never.
Well, I think that if the tube comes out and he shows an ability to rally with the best that we can do
Right.
for him, then we're all comfortable that we
Right.
do everything to support that.
Right.
And I think if I hear you correctly, that we're also at a point where if we are able to take the tube out and yet things take a turn for the worse, that we realize that
I don't
putting the
want
tube
the tube
back in,
back. No.
it doesn't do him any good at that
No.
point.
But you understand,
I understand, Charlie, but the tube bothers him. If he has the tube in him, then he's got to be sedated all over again because he can't tolerate the tube.
and if he has the tube in him, it's not living, really.
No, it's not
just-
living, he's existing.
Yeah, and we'd also face the issue then, sort of where do we go from there? Because then, would we try again to remove it and put him through that again? Would we try to keep him on it on a long-term basis, which would be miserable for him? And as you say, from a certain point of view, right, it's not the kind of life that
No.
And he
certainly that
wouldn't want
he's
it that way
wanted.
either.
Charlie would never want to be
No,
an invalid.
no.
I'm not thinking of me because for me it's lonesome. He suffered terrible the last 2 months. Maybe would have made a difference if he came in sooner.
I don't think that it would have.
No.
No, I really don't.
He kept saying the last month, Charlie was a bit of a crybaby, you know that. He gets scared of everything, every little pain. Like the little boy that cried wolf once too often. And they kept saying, Phil, I'm gonna die. I feel like I'm going crazy. When we came in here that Sunday morning, 4 o'clock in the morning, he was screaming. I don't know.
See,
I want whatever's best for him.
Well, I think we all want that, and I think we've done a little bit of work toward defining that in a way that we're all comfortable with
Yeah.
together. I'm going to be around for the rest of the day, and if you talk some more and want to be in touch again, they know how to call me.
the way you feel right now, the tube has to be removed. We understand that, right? We're
They're
clear
going
on
to
that.
try to do that within the next day or so. Anyway.
We hope. If things continue to go
things
well in
continue.
that regard, we'll be able to remove it.
In the event you can't remove it, then we'll have to.
Well, we'll face a different set of issues then.
Yeah.
It's much more difficult. If we
Okay.
can see that kind of improvement, there's a lot more reason to be hopeful if you can manage without it.
Without the tube.
And that's really our hope for the next couple of days, is to move in that direction. I think if a couple of days from now we're not able to do that, we'll have to talk some more and take it from there. But I think we really need, it's so complicated that it's hard enough with the one step at a time approach.
But you're moving towards the whole issue of if there's any chance whatsoever the tube has to be removed.
Right, it's got-
If there's any, then and that hope is as slight as it may be, and you can't even move beyond what will happen once they remove the tube. You just feel, and I would agree with you, by the way. I understand what you're saying, that if there's to be any chance, that tube has to be removed.
Right.
Okay.
Dr. Taylor, what can I say? I wasn't going to keep my appointment Friday, but I think I better commit.
Yeah, I think it would be good to see it.
He's my friend. He's not only a doctor, he's my friend.
It's good that you have confidence. That's
I
important.
do, utmost. Well, Thank you, Dr. Taylor. And I'm sorry I took so much time.
That's what I'm here for.
Thank
Any
you for
apologies.
explaining
It's good to get to
everything.
meet you. Good. I'll call you tomorrow if I don't see you later today.
All right, thank you.
Why don't you stay here? We're in the room with...
Why don't you ask him now?
Oh, that's...
I think he's got anoxic brain damage, personally. And I think he's got everything there. But I mean, there's no way to really assess that. I mean, it's, sort of in neurology, people wouldn't help us. We did want to get a head CT to sort of rule out any structural lesion, but I think it's unlikely that I mean, the chances that that's going to show anything are, I would think 1 in 10,000. I think it's mostly the guy with aortic stenosis who dropped his blood pressure, had a sustained episode when his blood pressure was running around 70, had an episode of hypotension when he went on the ventilator the first time.
Yeah.
And has a bad ticker and poor cardiac output, and that's all it takes, and stuff like that. So I mean, but you could also implicate the fentanyl, the Ativan, et cetera, et cetera, et cetera. So I mean, you never know. But I mean, you don't breathe up here; you breathe down here. So this can be all gone, and you breathe fine. So that's the experience up here.
Right, but he isn't.
But he isn't. But he isn't. He could have had an event there, but I doubt it. I mean, I think the reason he's not breathing relates more to the fact that his lungs and his heart are so terrible. And then I think we're going to have to address the issue with his wife. What do we do at that point?
Yeah. But you haven't given up on the idea that he might be able to be weaned?
No, not yet. But I mean, I think that I probably would still get him, even if we, I would get him optimal. And, the fact that he didn't wean with IMV yesterday doesn't mean that much either, because there's increased resistance to the tubing and the circuitry and so on and so forth. And when we took him off the last time, his inspiratory force was only 50 to 100. Well, that may have been one of the reasons that he failed the weaning attempt. But on the other hand, it's also true that he was actually doing pretty well for a couple of days there.
Yeah. But now seeing no spontaneous respiratory effort puts it in a little different category. Maybe, yeah. Alrighty.
Anyway, we got a little fine-tuning to do first before
you can see.
Yep.
Alrighty, thanks.
Okay. So what's the long-range plan? What do you see as the long-range
The long
plan?
range plan is we're going to diuresis him back down to his weight of 75. We're going to pull it out the tube and give it a try, and it's probably not going to work. What do
I
you
agree.
see the long
No,
range plan?
that's exactly.
That we're not going to reintegrate.
Yes.
Yeah.
He will not reinstate.
Yeah, I think that's the long-range plan. I think that's the. I mean,
So keep him ahead.
it makes me angry. We work so hard on this guy, and it looks so grim. I mean, it's just really discouraging. But I don't see any. We just got to get him to the point where we optimize everything, and then see if we can get him to fly here. We got a few more days. I mean, the big thing is if you can't keep him net negative a kilo, don't hesitate to start the dobutamine and dopamine back up. I mean, because he's on a negative inotrope now, he wasn't on before.
His pressures have been real good. Dopamine alone plus diuretics should probably stand him in good stead. The last couple of
So you
times
just need
he's
to keep
gotten
an eye on him,
diuretics,
go back
he's
and
done
check on him
real
after
well.
rounds, check on his urine
What is
output
it
if
that
he's
makes
not.
him penile? 200 and 200?
Yeah, that's 200 and 250.
250
250 a diurone.
to an IV So pretty much you just have to keep an eye on his urine output, and when it drops to now below Alzheimer's disease, just give him again. And he was on renal range dope for like a 2. And you can start that again. If the latex doesn't work.
Keep an eye on his potassium.
Yeah.
That's the other thing.
And the other thing on the cocaine is just the naphtha. He's got an elevated creatinine, and the naphtha's going to stay around. So just keep an eye on it.
He may have, 2 might be a little bit too much, but we'll see what the levels are this morning.
Okay.
TCs have been fine.
do is at 5:25, you have to do 4 days. You start to shoot
The goal is to wean him down, maybe even drop his breast one more tonight, see how he does. Maybe. I kind of discourage that. And try and get him off tomorrow.
You should let him rest overnight.
Yeah. I talked to the intern. He says he wants to go and talk to the wife and make sure that she is really adamant about not re-intubating him.
Oh, he's not to be reintubated?
That's the plan as of now. Okay, they feel that we've done everything medically that can be done with this patient. We've tried him out. We've buffed him up, nutritionally. He doesn't have an infection right now. We've done everything we can, and the aortic stenosis may be so severe that we won't be able to.
You're not going to take him for the valvuloplasty?
No.
Why is that?
I don't believe that he's a good risk at all right now.
So is he DNR?
Yeah. No pressors. And as it stands now, we will not reintubate. However, he's waking up a little bit more right now, and the wife seems like really very happy. And I'm just afraid that she'll say, well, I do want to intubate him now. So the Ho's going to talk to her today. Paul is on, and he's going to talk to her tonight, and really try to explain that we have done everything that we could, and he's a 73-year-old man with very severe disease, and does she really want him to live on a ventilator? Which I think has to be said to her. I think she has to be told in very plain language, what's going on, because I'm afraid that she's going to see him, a little bit more alert, responding to her, and we'll say, I do want him to live. I do want you to do everything you can. That just, came up rather recently.
And Louise, you have a call on line 5?
She might look at this and say, gee, I want everything done again.
So that, he went from 10 to 14, 10 to 12 to 16 at...
It's hard not
Do you feel like we can do anything more for him right now?
No, I think the key is to see how he does.
Extubate.
Yeah, 2 o'clock,
Yeah.
Because that was definitely what I got from rounds today.
Yeah. I can't imagine that there's much we have to offer him by getting him weaned and then having him back on the ventilator.
Right.
And the question is, can he fly?
Normal in urine, it's not
He's buffed. I don't think there's any
Urine
question about it. He's dry.
from
In fact, he's almost a little bit too dry. His blood pressure's been down today.
Of course I don't.
How down?
It's been down as low as 104
As far as his labs go, I don't
when he's quiet, and it only goes up to 140, whereas 2 days ago it was going up to 200, 180. So, and his sodium's up a little bit too, 152.
6.4.
Well, this may be as good as he can be to see how he does off the tube. And he's having some spontaneous respirations up to about 10?
Yeah, pretty poor quality, but
there was a mistake.
And obviously they're oxygenating him well enough. His gases have been good. I don't know if you've seen the blue chart. His gas, he's retaining a little bit more CO2, but besides that, the oxygenation's okay. The O2 sat's about 92%, so can't get much better than that.
Yep.
And what's his baseline gas? The nurse was just asking. I wasn't sure.
I'd have to check. I think it's around 50-50.
125.
What you'd expect then. Okay.
Don't put...
They may throw us out of the room.
What about the brain scan?
Preliminary result on that scan is that it's okay. They couldn't get as good a study as they'd like to get because he was moving a little bit. But with everything they could see, it looked fine. So as near as we could tell from that, no problems apparent on that.
Thank God for that.
Yeah.
But the nurse said they're not sedating him as much because are you thinking of getting him off the respirator?
That's the hope. We're hoping if things continue to go the way they have been today, that maybe by tomorrow he'll be able to come off the respirator.
You think he'll be able to breathe on his own?
Well, we're not going to take him off of it unless there's a good sign that he can. What'll happen after that, we don't know. I mean, right now, things seem to be in the optimal situation to maximize the chance that he will be able to manage off of it. And that's clearly the best time to work toward getting him off.
You mean this doesn't mean that he's coming off?
No, it means he's moving in that direction. If he has continued improvement the way he has today, that he should be able to have the tube come out and be off the respirator tomorrow. But it's still, it's still critical enough that it's still one of these one step at a time kind of situations. But there's some
What does it actually do? I mean, if he comes off of it.
The respirator is breathing for him. It's doing the breathing. And right now, he's taking some breaths, but not enough to maintain enough oxygen.
Oh, I see.
But yesterday he was taking virtually no breaths on his own.
Oh.
So if he can take more and more, as we turn the respirator down and down, if he takes more and more so that he can maintain an adequate amount of oxygen in his blood, then we can turn off the machine. But we have to do one step at a time. We turn the machine down and down and down and watch and see if he can, as it's being turned down, respond by breathing a little bit more and a little bit more. He has to be able to breathe enough himself to supply himself with enough oxygen.
You know what puzzles me, Dr. Taylor? He was in here 3 weeks before that, right? Or around that.
Yeah.
Nothing of this could be detected.
Well, what was detected is what we've known about for years, which is that he had very serious lung disease.
But I mean, I'm talking about the heart.
No, his heart actually, it seems that what's happened is a combination of all these different things that all together have pushed him to the side of this critical illness that he's got. The largest contribution is probably his lungs. Another contribution is his heart. Another contribution is his kidneys. All these different things that are in trouble are all contributing to how poorly he's doing. But his heart, in July, just a few months ago, he had the most sophisticated heart evaluation we know how to do.
Yeah.
And at that time, his heart did not look too bad. I mean, there were problems. We knew about them. We needed to assess how bad were they. But
and
they weren't.
Kidneys. He never had kidney trouble.
No, that's really a complication of everything else getting into trouble. When the blood pressure goes down, when the heart isn't pumping effectively, when the...
Oh, you mean these things cause this?
Yeah.
Oh, I understand. It just puzzled me. Because I said, if he had these, he's always, how he is about coming for his checkups.
Yeah, I know.
And I said, well, I know a couple of times he had back trouble.
Yeah. That was for the urinary tract infection.
It had nothing to do with his kidneys.
No, no. Well, I say no. Probably that infection was just in his bladder. And certainly he didn't have any kidney damage from that. So that seems to be totally unrelated to the kidneys not working that we've seen recently.
If he comes off the respirator, is it something that could recur?
Could he need the respirator again in the terms of...
In the future?
Well, we don't know. It's a real important question, and that's what we talked about a couple days ago when we talked about if he comes off of it, should we subject him to it again if he needs it? He could be in the situation where his breathing on his own is inadequate to support his life. And that's the issue that we have to be sure that we're all comfortable with, or as comfortable as you can be in terms of a decision. Because the decision that we talked about a couple days ago was that when he comes off of that respirator, as we hope that he will, that we'll do everything to maximize the chance that he can stay off of it. And what we had come to together before was that if he then takes a turn for the worse, that we're not going to subject him to the tube and the respirator again.
I don't want to do that.
Yeah, well, I think it's the right decision from a medical point of view, because I can't imagine a situation, if he did take that sort of a turn for the worse, from which he could have some sort of a recovery.
No, Charlie wouldn't want that kind of a life.
Well, it's terrible to have to be facing that issue at the same time that that we have the hope that comes from seeing him doing a little better. He's taken one step forward. There are many, many more steps to go in order for him to have any sort of recovery from this, but it's a wonderful
But
thing.
it could be.
We don't know. That's right. You know, and before we were looking at, even if he had a day without further problems, that was a plus. Now he's had a day where he's actually made a little progress. So
Yeah.
although the hope is, you know, as thin as a thread, there's hope. And we're doing, you know, everything that can be done to try to maximize the chance for some sort of a recovery. And as you suggested with the question that you asked, it's going to be a critical time. If we can get him off the machine, it's a critical time to see if he can maintain some sort of improvement. Because if he takes a turn for the worse at that point, there probably will be nothing that we can do.
Well, I can understand that. I just don't know how these things happen. He's like the boy that cried wolf once too often. He was not a hypochondriac, but he always worried about little things. You know how he was.
Mm-hmm.
But I never saw him like this. Never. And Charlie's been in and out of hospitals. Never. Never seen him like this.
This is the worst it's been, I'm afraid.
Yeah. What does Dr. Morgan think? The same as you?
Yeah, well, he's been very helpful in terms of making suggestions about adjusting things from the point of view of helping his heart.
Yeah. Well, thank you very much for answering my questions.
I'm going to see you in the office tomorrow.
Yeah, I canceled Charlie's appointment. And the first time I laughed in a long time. I don't know who the girl I caught was. But I said to her, you know, I was going to cancel. He's in intensive care in the hospital there. Does that mean he wants to cancel his appointment? Well, that did me in, you know. I said, yeah, I think it does.
Yeah, there's somebody new down in the desk there. I
Oh,
suspect
must
that's
have
who you
been.
spoke with.
I didn't think you'd roll him up from here down there to get an appointment.
I roll myself up here to see him instead.
Right. Thank you very much, Dr. Taylor.
You need to go look at him. I'm told that he's more awake and indeed was responding to command by nursing.
That therapeutic head CT.
Great.
That's right. That's all it takes.
Great.
And Lorraine really lightened up on
Good. We got
Did he get any mechanics today, or?
No, he's breathing a little bit. I didn't ask him to try to do
All right,
that.
so we'll get those first thing in the morning.
Yeah, I think we're going to try to
Yeah.
pull his tube
do it
tomorrow.
Dr. Taylor's just talking to his wife, so.
Hi, Mr. Speraza. Good morning. How are you this morning?
Mr. Speraza, squeeze my hand. Squeeze it again. Can you squeeze? Mr. Speraza, squeeze my hand. Squeeze over here. Yeah, squeeze. Good.
Today's the day. We're going to get that tube out today. Big day today.
We're going to take a listen to your heart and your lungs.
Administrative answering page on line 5. Administrative answering page on line 5.
That way it works better. Softer and more sensitive. Is it cute, my friend? Yes.
Yeah, that's what we discussed last night. I think that there's no way that
Squeeze my hand. You know it's me? You know it's me. Charlie, you're breathing on your own, you know. What's the matter? I was downstairs with Dr. Taylor. Charlie, Julie's coming in. Do you want to see Julie? Squeeze my hand, Charlie. Want to get up and take a walk? Why is he breathing so heavy?
There's no secretions in his throat after we pulled out the tube, so it's going to take a while. We've been suctioning him quite a bit, so.
Here I am. Here I am, honey. I didn't drive in. Debbie drove me in, and she's coming up here. She was with you last night. What's the matter, honey? What's the matter? I know you don't like that scoop up there, but it's better than the one you had in your mouth. Is he you know?
He's breathing all right. He's breathing kind of rapidly, yeah. But he's okay. Taking nice big deep breaths, so.
Is he?
Yeah.
Looks like I'll have to go on a diet to compete with you. You wanted to lose weight. Now you lost it. Okay, honey. Okay.
She's on,
I did go to a trustee dinner last night. You know, Mitch has these dinners with the trustees.
Yeah, good eats
And the topic, no, it's
Show off the professor.
the rubber chicken. No. It does this to sort of get the trustees to be more educated about the hospital. But the topic that we had to discuss was how to cut the hospital budget 3 to 5% to accommodate the decrease in revenues associated with, the lack of healthcare legislation in the state. Anticipated $5 million deficit. So basically, I think the businessmen and I were the only people at the trustees and I, the only people who manage our own budgets, said, 3 to 5%, no problem. You can cut 3 to 5% out of virtually any budget and you don't have any problem. But that doesn't really solve the problem, because the problem is, how do you explain to the American public that if they want to have everything done for everybody, that it's not only going to cost what it costs now, but it's going to go up every year as the number of older people go up. Two-thirds of all your healthcare costs are incurred during the final 21 days of life. And I thought that it was, 2/3 like in the final, or half in the final year. It's even worse than that. It's 2/3 in the final 21 days. And the problem is we can't tell who's going to make it and who's not. All right, so shoot.
Mr. Speranza had a relatively good day yesterday. As I gather you heard, there was a period where he apparently recognized his wife and would respond to commands to nursing, and indeed at one point when I went in, he would squeeze and release my hand on command and was attentive to his name, and so some improvement. Mr. Speranza, good morning. How are you feeling? You squeeze my hand? Come on, squeeze it hard.
Did you do it?
Yeah.
Did yesterday.
Can you wiggle your toes, Mr. Speranza? See you wiggle your toes.
Yeah.
Great. Good work.
You're doing good, Mr. Speranza.
Yep.
You don't want bed at all?
Pardon me?
Did you get out of bed at all?
Yeah, into a chair, yeah.
Squeeze my hand, Mr. Speranza. Mr. Speranza? Squeeze my hand. Can you do that? Okay. I'm going to let you get some rest, and I'll come back to see you again.
See, they're questioning pneumonia in the right base. He should probably actually go on chest PT again, but I'm sure he'll have more XP with that, so I don't know.
That's when he died last time.
Yeah. Yeah.
Just PT and he stopped breathing. Okay.
His rate's been a little higher than it was, 38 to 40. I mean, definitely looks labored. It looks like he did before he respiratory arrested the last time.
Is he using his belly and stuff?
Yeah. Yeah. Asynchronous breathing and all that kind of stuff.
So if he just stops breathing, we just like let him stop breathing. That's so weird.
Very, very concerned. Can you squeeze it? Squeeze my hand? I've seen people come back from this. I mean, it's not, it's just that the odds are, really against him, in terms of his coming back from it. And there's still a possibility that some of this could be metabolic things. But I have seen some people come back from it. The chances are, with all of his problems, you're looking at a less than a 5% 6-month survival at the very best. And probably, much worse than that.
Medical intensive care.
Okay, just gonna do this side now. I'm gonna put your oxygen over here. Can you look at me?
Ow.
Sorry. Cough it up. There's your oxygen. No, don't shake it off. Just keep it right there. No, don't taste it. It tastes gross. Keep your tongue in your mouth.
Ow.
What? Well, put your chin up. This tube hurts, huh? Yeah. Good.
this is where sort of clinical epidemiology and clinical medicine sort of don't intersect. If you take 1,000 people and you do these incredibly dangerous interventions to them, statistically, a rare 1 or 2 or 3, end up with a bad outcome.
Okay, because vagina doesn't need to be done.
Without any apparent, because it's it's high risk. I mean, you just think about the stuff that we do. Taking away somebody's bone marrow and then giving them mega doses of chemotherapy and then infusing it back into them, or giving them 6 toxic chemotherapeutic agents in sequence and watching their white count disappear. And sure, you may get away with it 900 times or 990 times out of 1,000. But there are going to be a few people who are going to have, an incredibly... And the other thing, the other thing is the way a lot of chemotherapy is presented to people, too. I mean, take a guy with oat cell carcinoma in the lung. You can say to that person, well, we can double your life expectancy. We can take you from living 3 months with no chemotherapy to living 6 months with chemotherapy. But for that 6 months, you won't be able to swallow anything because your mouth will be raw. You'll be constantly in the hospital and infected, but you'll live twice as long. But that's not the way it's presented. I mean, you don't present it to a person. Well, we're gonna have you live twice as long, but there's a morbidity associated with living twice as long. Or you can live short and sweet and.
That's a fallacy. It isn't short and sweet. That man with oat cell carcinoma is in marked respiratory distress.
Well, maybe,
I buy your argument.
Maybe he gets 2 months and then you give him morphine. But
that may be. It's not like you live well with untreated cancer until the day you die. You're in horrible pain and worsening respiratory status, and you're
maybe pain, maybe not. I mean, you can treat the pain. But, no risk is zero. No risk in medicine is zero. And the problem is, is that the culture, we blind ourselves to all of that stuff. Because we have to. Because you have to be a true believer. You have to believe in this stuff to do it. If you didn't believe that this stuff would work, why would you do it? I mean, and faced with Larry Shulman's dilemma, a 38-year-old woman with 3 kids, where you have a choice of doing nothing and watching her die over the course of a year, or doing something and
for a small chance of survival.
Right. I mean,
I agree with this choice.
Well, it's hard not to do the other thing. But I think the problem is when you do that, then you sometimes end up shortening some people's lives, and so it's a no-win, because it's not, it's manipulating things when you don't really have an awful lot to manipulate. In the short term, who's got the better prognosis, Mrs. Factor or
Bornay's patient?
No, this lady.
In the short term, Mrs. Factor has a better prognosis. On the other hand, I believe ICUs are for this lady, not for Mrs. Factor, frankly. I mean, that's it's an age prejudice that I cannot beat.
That's ageist. I mean,
it is ageist. It isn't age, though. It's just her disease.
Right. It's an emotional response to the situation. Here's this 38-year-old lady. She's got 3 kids.
No, but I don't believe Mrs. Factor can never be cured. I cannot fix hypertrophic cardiomyopathy and bad lungs.
Pleural mesothelioma can never be cured either.
Unless you believe, as oncologists believe, that she has a 1 in a million chance of survival with this chemo surgery plan for her.
But you see, I think it's important to recognize that is
no hope for her.
Yes, I would say that there is no hope for her. In fact, that her hope is less than Mrs. Factor, and in fact, I think that borders on the same kind of religious faith that I happen to believe in God. I have very strong faith in a supreme being, and yet I'd have to say that belief that you can cure that is exactly the same sort of blind faith.
But yet some mesothelioma patients are cured.
Yes, but much more commonly pleural mesothelioma. Sure. I mean, but you have to think about what kind of cases. They're not pleural mesotheliomas like this.
I mean, if you really believe that there's no hope, then this chemo is a farce and cruel, and this ICU stay is a farce and cruel.
Well,
I can't believe that.
right. I mean, I think you.
I mean, I cannot stay up all night with this lady and flog her and get excited about DIC improving and all this stuff.
You cannot do what you have to do.
That's right.
If you believe that. That's exactly what I said. You have to believe in it.
And I can't actually be a doctor for most of my patients because, you know,
well, that's. I mean, I think that's part of the problem. I mean, I think that's part of the problem. 'Cause I mean, I really do believe that from the moment that diagnosis was made, it's like in Treasure Island, you know, when the old captain gets handed the black spot. She got handed the black spot.
So it adds a little.
She was called, and
So therefore
we're
we should
minor
not
actors.
So therefore
We're
we shouldn't put active.
No, I don't say that.
I mean, you know,
I don't say you shouldn't or you. I think that it's important to recognize that. Look, I mean, you know, I said putting this on, but I think it's important to recognize the reality, you know, of what the situation really is.
But I mean, when you first diagnose a patient like her, you know,
well, I think the doctors. I think
your heart sinks, but you can't just give up on her. You aren't doing her a favor by giving up on her either.
I don't. See, you say it's giving up. You say it's giving up on her. Well, you know, maybe it is giving up on her. I mean, that's one view of it. That view would suggest that we have something to offer. But what I'm saying is that it's not clear we have anything to offer.
7.18.
And in fact,
and her
what
like 73.
quote the system?
On the way down.
Because I mean, you know, I think I, you know, very well might have done the same thing that Larry did, but I think that it's important to recognize that the system probably shortened her life. There's some things that are bigger than us, you know. I mean, bigger than what we and doctors in this day and age, you see, are extremely reluctant to say we can't do anything for that. We have no way to help that yet. I don't know, you know, it's hard. But you know, I mean, it's so much of this stuff is heavy flail for relatively small or no gain. I mean, a number of people, you know, I mean, having built this thing, I have serious questions as to its utility.
Oh yeah, I mean, you know, in all the months that I've been here, you know, 3 years in a row, there aren't very many patients who you actually sort of help save their life, make a major difference.
I mean, we know that everybody who rolls through that door looks bad. They look bad. They could go any time, but you know, we can't tell you when. That's the problem.
I mean, it's
I don't know. There's nothing more discouraging than this, though. This is the psychological toll on us and on the family. It's just really grim.
So I'm going to put this. I'm going to put this on top here. Is that okay? Yeah, yeah. Can you hold on to that? Yeah. Okay. Hold it. Ow. Okay. I can put it up here. We can take a table with us too. Here we go. Okay. Okay. You can get that?
Yeah.
Okay. What?
I got Dymox Dyro on my team. You get Dyro on my team. Second problem, ID, you have a problem.
This guy has a otherwise pretty simple situation.
Right, but as with everything you do, there's
Yeah, the other thing with ID, and instead of putting it as a public one,
potential risk and potential benefit. Definitely not hurt to have the ultrasound.
It would settle more definitively than an X-ray if there's anything significant.
Agree with that.
Other issues, substantial metabolic alkalosis, which seems to be reasonably well compensated.
Not here.
Milk and intensive care can help you.
For the last couple of days.
Did you get a hold of the funeral home?
Yes, I did. Yeah. Yes, I did. Thank you much.
No problem. Okay, if you get on that side and just take the sheets. 3, 1, 2, 3. Okay. Coat tag.
All right, I guess you better.
I want to get home and find out.
Find out I got the wrong money.
Okay.
Over to Dorothy.
Yep.
She will pay. That'd be good.
Let's over. She's gonna have to come down a little bit. Okay, that's.
That doesn't work.
Got your pins?
No, I don't have any. I want to go that way. Okay.
Take care. See ya.
Good to see you.
You're all done with your papers.
Yeah, I got all my papers, yeah. Okay,
Bye. Take
thank you
care.
much. Yeah.